as well. I work with Raki on Ward 16 at DRI. I initially started my QI project trying to improve communication between A&E and the stroke ward. But I had to sort of change my project idea because we're bringing in some different setup for stroke at DRI. So another thing that I wanted to look at was communication between Bassetlaw A&E and our stroke department over in DRI. Basically just wanted to look at the communication between the two. So we do have some issues with communication between Bassetlaw and the stroke team, mainly because we don't have a stroke service over in Bassetlaw. So in DRI, what the normal process is, we get a phone call, a pre-alert from an ambulance to warn us that a patient potentially with stroke is coming into DRI A&E. We'd go down and see them. We'd do the NIH assess, as Raki has told you about. We'd scan them, we'd treat them, and we do everything pretty much from as soon as they arrive. But obviously we don't have that service in Bassetlaw. So if there is someone having a stroke within time limit for treatment, we have to rely very much so on a phone call from the clinicians in A&E, who obviously don't see stroke as much as they obviously see stroke very often, but they don't do it as regularly as we do, and they don't sort of have the same sort of routine that we have when we've got a patient coming in. And it does cause us quite a few issues. So not just with patients who need treatment straight away, because obviously those patients need to come to DRI as quickly as possible, but we also have an issue with patients who don't really need to come to DRI, that are being sent by Bassetlaw when they don't necessarily have stroke symptoms, but we've not been able to assess that ourselves. There's lots of patients who come to DRI who we're pre-alerted by ambulance, but they don't need to come to us, and it's not really the stroke symptoms that we think they are. We sort of often have mismatch, so it's more difficult with Bassetlaw. They just have to sort of send across people they think have had a stroke, and we end up with patients coming unnecessarily. So I wanted to obviously just work through that and see if there's any way that we could improve that service. So like I say, currently there is some poor communication between the stroke team and Bassetlaw. So I wanted to try and reduce this poor communication, so reduce how long it takes for patients to come across to DRI if they do need treatment, to increase the urgency of the scans that they're having, and just to try and improve the assessments that patients are having in Bassetlaw. So I wanted to look at patients who were booked into Bassetlaw over the last few months and see how many were sort of inappropriate, and try and reduce that those transfers by around 10%. And we sort of looked at the cost, the current cost. So I mean, I don't know the specifics, you could probably help me with that, but transferring patients by ambulance to Doncaster, waiting for beds, taking up a bed on a stroke ward when they really didn't need to. I'm sure the numbers for that are quite significant. The target was obviously to reduce how long people are waiting for to come over, because we can just send them home with a referral or something, or they can go to the more appropriate area that they need. So also looking at morale, it's these miscommunications, they can result in staff on either side thinking we're not really doing our job properly. So clinicians in Bassetlaw might think, well, why are you not happy with this referral, or why are you not accepting it? And we can also think, well, why are you sending these sorts of referrals? So we want to just improve this communication and teamwork between the two departments. So the suppliers in this are paramedics, family members, patients, the Bassetlaw doctors and ACPs, all the clinicians, and a triage team. It just works through all the people who were involved on that slide. So I had a sort of discussion. I had a similar issue to Raki really with being able to get everyone together. We all work various different shifts. We're never in, there's only one of us on at a time, so we're never in like the same place. Obviously we work nights as well. We aren't going to see our consultants overnight, but we have managed to sort of discuss the issues at different points. So I've discussed with consultants and the ACPs that are on the ward, and with some of the people in A&E as well.
Halfway through, Ross.
Thank you. What we managed to do is sort of map out the current process where the patient's admitted to Bassetlaw, they're triaged with having stroke symptoms, they are assigned an A&E clinician who take their history and find out the time of symptom onset. They do a clinical assessment confirming that the patient has stroke symptoms. They then do the appropriate imaging, so CT head to make sure there's nothing else going on, and then they'll give us a call on the stroke nurse or ACP phone. We then just take the details over the phone. We'll have a discussion with the consultant if we need to, and then we'll accept that patient to be transferred over to DRI or wherever they need to go. We can also send people directly to Sheffield for thrombectomy, and that depends on the score that they get on this NIH scale. So it's very important that we get these numbers right, because they might end up in Sheffield and not really have the symptoms required for such an invasive procedure. So that's also very important. So as I've said, there's the issues with the current process is that there's no stroke team in Bassetlaw. We're relying on these phone referrals. We can send patients to Sheffield, but we need to make sure we're getting the symptoms right. They might need transferring to Doncaster very quickly, depending on the assessment, and we do get some inappropriate referrals of patients who don't need to be referred. So I did have a look at the data, and since January, 52% of patients who have come from Bassetlaw and ended up with a confirmed stroke have actually only 52% of patients who've come from Bassetlaw have ended up having confirmed stroke, which, you know, it's not terrible, and ours could do with improving as well, but 66% of the patients that we take from Doncaster A&E end up having a confirmed stroke. So there is a definite difference from what gets sent over. So from the scoping meeting, we decided that probably the best way to go about improving this communication is to implement a video calling service, where basically we're going to get a computer on wheels that you can wheel around, and depending on what the referral is and what time the symptoms started, it will decide whether to do a video call with the A&E clinicians, and then we can do an assessment of the patient ourselves, asking them to follow our what we want them to do. We also decided that we need to sort of improve the knowledge of the patients in the Bassetlaw area to make them aware that there is no stroke service in Bassetlaw, so that they can make the decision to sort of come to Doncaster. If they're thinking to drive quickly to Bassetlaw, they'd be better off coming to Doncaster straight away rather than having the process of being referred from Bassetlaw. So we also thought that was probably a good place to start. So introducing video calling, improving communication, and also training staff in the A&E in Bassetlaw, not only to use the video calling software, but also to, you know, improve the assessments that they're doing by a few training sessions. So far I did one set of comms for Bassetlaw patients to see, which went on the Facebook, and apparently it had quite good, people looked at it quite a bit. I've written an SOP about implementing the video calling, so it's literally just a Teams call, but it's to make them aware of sort of how to do it and when with the times that we want to do it. So I've written a SOP for that, and that's going through governance. And then once that's all gone through and everyone's happy with it, we're going to start training staff in A&E how to use the video calling and when we need to implement it. So this is the picture. This is just a screenshot of the Facebook posts that we did just to try and help people in the Bassetlaw area be more aware not to really go to Bassetlaw if they think they're having a stroke. And obviously we're just waiting for that SOP to go through governance. So On reflection, this meeting has been really helpful. I've been thinking about doing this sort of communication improvement for a while, but didn't really know how to go about it. And this has sort of just rocketed it really, got it all started. So it was really helpful. It made us think of a couple of different approaches, not just the video calling, but also like in helping improve communication and making more people aware of the service that is available at DRI. It helped me to sort of assign who's going to get involved, and it really got the consultant on board, and them being involved means it sort of moves a bit quicker, and we're almost there getting it implemented, so just waiting on a few bits. That's it.
Brilliant, Ross. Great work. Thank you very much.